Okay, we're at 1718 and it's 7:02. So Long, are you there?
Hey Victor, I'm here.
All right. Okay. Thank you for volunteering. Let's um let's go ahead with case number one. It's a 2-month-old, our favorite age group to deal with. And Long, so this is a 2-month-old female, relevant to us is she's twin, X37 weaker, and she presents with a 4-day history of lethargy, vomiting, and reduced oral intake. No significant history otherwise. Well, what you may note, and it's not here, is she actually was in an outside hospital ER a week before with irritability and was diagnosed with colic and discharged home with famotidine. But otherwise, nothing else significant per the family, per the parents, and nothing else of note. But on exam, she has a pretty serious examination. By the time you get to her, she's lethargic, arousable to stimulus. Pupils are fixed downward gaze and has very minimal movement to stimuli with a tense anterior fontanelle. So just a couple of these things, just based on this history, what's going through your head?
Yeah, I think I'm very concerned for elevated ICPs,
Yeah, why
possible,
is that?
obstructive hydrocephalus. Um,
Why is that?
just given the tense anterior fontanelles.
Exactly, exactly. So, what type of imaging do you want, or what do you want to do? What do you want to do, Long?
Um, well, I think I'd start off with either a head ultrasound or stat CT.
Mm-hmm. And that's to make sure you can see what's going on. Okay, so you get a head ultrasound, and go ahead and why don't you tell us what you see on this head ultrasound performed to bedside?
Yeah, it looks like uh, significant, so coronal and sagittal views, significant hydrocephalus, as well as the hyperechoic lesion in the posterior fossa. Um, I think probably either needs, to be temporized with a transfontanel tap or an EVD, and then follow that up with an MRI with or without.
Okay, okay. So in your mind, this imaging shows hydrocephalus that is symptomatic and requires some sort of diversion, at least temporary diversion, to get the patient to a more intense sort of imaging, correct?
Yeah, exactly.
Yep. Okay. Okay. And indeed, that is actually what was done. The patient underwent a transfontanel tap to take off CSF pressure and then proceeded to an MRI. And the this here is the T1 sequences with contrast. So why don't you go ahead and just tell us what you can see here?
Yeah, so axial sagittal coronal views looks like a heterogeneously enhancing solid cystic lesion in the posterior fossa. It's hard to tell if it's arising from the um it's hard to tell if it's arising from the pineal region or the cerebellum or roof of the fourth ventricle. I think included in my differential would be pineal region tumors, which includes, primary, uh, uh, pineal parenchymal tumors like pineocytoma, pineoblastoma, pineal tumor of indeterminate grade, also germ cell tumors of the pineal region. Um, Less likely, I think, is something like pilocytic astrocytoma of the cerebellum or uh, something like penamoma. Um,
Okay. Okay, yeah. Nice broad differential. And obviously it's a very interesting looking lesion on imaging, given the patient's age. Let's just go ahead and just quickly before we think of anything else, is there any type of other parts of the body you want to image? Any sort of markers you would consider?
Yeah, I would definitely get germ cell tumor markers. So like alpha fetoprotein, um, uh, LDH, beta HCG. Um,
Excellent. There's one finding for you. Um, but you know, it's really hard to integrate that into your findings because I think the other samples were lost. This was the only serum marker that was reported. It's elevated, which does that shift your differential or does it still keep it, you know, in those sort of categories for now?
yeah, I think that shifts my differential more towards, germ cell tumors of the pineal region. I think AFP is like elevated in like yolk sac tumors, immature teratomas, and I think that's mainly it.
Yep.
Um,
Okay. Cool. I found I don't know if anyone uses this mnemonic, but I found this MAGE, which goes ahead and describes posterior fossa tumors in kids, which I thought was pretty good because this mnemonic actually goes in the order of prevalence, except for the ATRT component. I think you mentioned teratoma in your differentials as well. But again, that would probably be at the end of everything. But I think this mnemonic is very nice. This medulloastrocytoma, glioma, ependymoma. So yeah, put that to memory like I said, I thought this was a cool one. So this is all what you said. So great. So obviously now you have this child with this large posterior fossa mass. The patient is 2 months old, and you've temporized with a transpontanal tap, but nonetheless the patient still has a very large lesion in the posterior fossa. She's symptomatic. Um, we have to think then of how we're going to treat. So what goes through your mind, and you know, there's not necessarily one way to skin a cat in this situation, but what would your treatment ideas be for the tumor and for the hydrocephalus?
yeah, so for the tumor, I think can attempt like a resection and biopsy for tissue for pathology. I think also if you are able to get enough of a resection, you could also probably alleviate a certain amount of mass effect, which would treat the obstructive hydro. Um, Another way to treat the obstructive hydro would be like maybe an endoscopic third ventriculostomy.
Mm-hmm. Mm-hmm. No, exactly. And so, um, you know, the considerations that you've said are all viable. What makes this case interesting is the patient is very young, that and can tolerate only a small amount of blood loss. So some people could favor a more minimally invasive sort of approach versus some other people would consider it, you know, if the tumor is accessible, then you can go for a section if done carefully. So I think you nailed everything there. And so this patient underwent surgical resection. And Dr. Gultikan, let me bring up the pathology slides. 1 second. Here we are. Here are the pathology slides. So Dr.
Can you
Gultikan,
hear me?
if you want.
Can you hear me?
Yes.
Okay. So I have an echo here. Sorry about that echo.
Yeah, we can hear you.
Okay. So this was the intraoperative smear. And it shows a very deceptive, almost like a small round cell tumor appearance. And I think it's difficult from here to conclude what actually the diagnosis is. It's probably a busy tumor stroma that is depicted here, but I think in the actual frozen tissue, the correct diagnosis was rendered. Next.
Hmm.
So here it is. You can see a variety of tissues. I hope you can recognize the cartilage in the center. There are two geographic pieces of cartilage in the center. Immediately, when you see this kind of thing, you may think of the diagnosis. On the left, there seems to be some glandular tissue. At the top also, you see some glandular tissue. So there's a heterogeneity of tissue components here, which makes you think of teratoma. Next. Here's another view. On the right bottom, you can see cerebellum, normal cerebellum. And the rest of the tissue is variegated with cystic component at the top. And in the middle, there's also cartilage beyond it. I'm sorry, below it. Next. So this is the critical component. This looks like a immature teratoma because we see fetal type immature neuroepithelial component here. You can see the tubules at the top left, and then some surface epithelium-like areas, primitive, poorly differentiated neural elements on in the rest of the tissue. So this is the critical part. Next, you can see here some mucinous epithelium in the middle. Next. And this shows on the right side some fibroadipose tissue. The clear cells are adipose tissue. On the left, there's like a almost like a low-grade glioma, like the neuroectodermal component. It's not tumor, but it is fetal, so it's not very well differentiated. The left half of the picture is that glial component, not glioma, but glial component. Next. So there you go. You see this relatively cellular glial component with a myxoid background that is very difficult to distinguish from a low-grade astrocytoma in an adult patient, interestingly. Next. You see bone on the right side, cartilage on the left side. Next. And this pink transverse bands are skeletal muscle, striated muscle. So as you can see, there's a variety of tissues here with a fetal immature neuroectodermal component. Next. You can support the neuroectodermal component with synaptophysin. Next. This is Ki-67. You can see that different types of tissues are readily proliferating, therefore very intense Ki-67 positivity proliferation marker in certain areas. That's it?
Yeah.
Yeah, so this was signed out as an immature teratoma by Dr. Laxon, who is also a pediatric pathologist. So well positioned to actually look at this case as a neuropathologist and a pediatric pathologist. Immature teratoma.
Okay, thanks, Dr. Gultika. And here are just some photos of the procedure itself for everyone to see. You can see the big image is the intraoperative image with tumor deep into the right of the image. And this patient underwent a suboccipital C1 laminectomy dural opening with duroplasty for a very good resection, as you can see in the post-op images there. So just quickly, teratoma is obviously one of the favorite pathologies we love to study and know a lot about, but it is it's a tumor with tissue derived from all three germinal layers, and it's usually well differentiated in the setting of mature teratomas, which you can see here. In our case, it was an immature teratoma, which you can see has less differentiated tissue from any of those layers. And this was an interesting percentage reported that 50% will die within 1 year. Pineal teratomas are more common, and Long had mentioned suspicion for the pineal region involvement. and must sample thoroughly for correct diagnosis, which was doable through the resection approach. Some more details specific to immature teratomas, they are rare and they are a germ cell tumor that is typically found in young patients. But again, you can see these percentages are not very high at all. Among the histological types of teratomas, immatures are known as highly malignant, fast-growing intracranial tumors with a poor outcome and challenging for diagnosis. It was difficult to find really evidence on epidemiology for these intracranial cases, but one study suggested this can be as high as 30 to 50% of the congenital brain tumors, those infants born with brain tumors, but much smaller, obviously, across all ages. And congenital cases are usually fatal, going back to the high degree of malignancy here. With respect to clinical features, they kind of mirror the mass effect in a posterior fossa when it occurs there, and that was the case here. And you can see the associated deficits, which the patient also presented with. And it is now when I look this up into more detail, it is the most common germ cell tumor in infants age under the age of 1, which again goes to the most common intracranial tumor in newborns and congenital diseases. Clinical symptoms are difficult because the patients can't really tell you what they're feeling. And so it takes a lot of clinical acumen, and perhaps that's part of the reason why the patient went to an outside hospital earlier and diagnosed with colic. These are rare, specifically where they're located. I think I found 5 case reports in the literature for this and 1 case series of about 7 patients. So, it just supports the fact that these cases are very rare indeed. Just quickly to wrap this up, Long had mentioned biomarkers, and here is a list of our favorite biomarkers, not only the serum biomarkers, but also these extra markers here you can see to the right. What I found interesting was, although it may not be accurate, elevated serum AFP may suggest a higher likelihood of immature teratoma than mature teratoma, and that's indeed what we saw with our findings. So,
Hey, Victor, great job. Just 2 quick questions. I mean, the fact that she presented so young, does that make you more suspicious that it's going to be highly malignant? And the second is, do you think that these tumors start in utero?
Yeah, thanks, Dr. Levy. My understanding, and if anyone could feel free to jump in and let me know otherwise, but yes, I think the younger these patients present, the more concern you have for this being something odd, something weird. My experience and knowledge of congenital tumors, however, also demonstrates though that they don't always act and behave the way they should. There's an example, and we did a case series looking at congenital GBM, and infants with GBM tended to actually do better than adults with GBM, which to me tells me that they don't necessarily always follow what we expect them to do in adults. And the suspicion is the molecular genetics and the drivers of mutation may be different. So I think in this case, the immature teratoma lends itself to a worse prognosis, but overall, I think it's very genetic and histology based. With respect to when it began, it is one of the most common congenital tumors. So the suspicion is that it does start in utero. Whether or not imaging techniques are sensitive and specific enough to pick it up, I think still remains to be seen. But specific to these immature teratomas, they were listed as one of the most common congenital tumors upon delivery. I think what limits a lot of our study is the rarity of these cases and collecting enough patients. As you can see, this one was limited to case reports, but yes, I do believe this is considered an in utero tumor. Okay, let's move on. Let me see. Imad.
Yeah, I'm here.
Okay, let's go along. Keeping in our theme of young patients that we love to see. This is a 3-year-old female that presents with 3 episodes of vomiting, and the parents describe a 3-week history of unsteady gait and lethargy. Otherwise, no significant type of history. On exam, the patient is noticed to have a left foot drop and have clonus both sides with a head circumference of the 98th percentile. So what are you thinking based on this exam alone?
It's kind of an interesting picture. It sounds like they have almost like upper motor neuron size, given the clonus and And but then also thinking something maybe intracranial if the head circumference is, above the 98th percentile, I would probably start with at least a CT of the head, then go from there.
So she's 3. So would you? She's otherwise not decompensating. Would you consider any other imaging, given she's so young with radiation exposure?
Maybe like a fast MRI.
Mhm. And so yeah, she was organized for an MRI, which you can see here. These are all the T1 images with contrast. So why don't you go ahead and tell us what you can see?
Yeah, looks like she has a large cystic lesion in the cerebellum, eccentric to the left, uh, complete effacement of the fourth ventricle, obstructive hydrocephalus, um, just contrast enhancing scans. So it looks like there's at least some kind of mural nodule within that cystic lesion. Some of the things I would think about are for posterior fossa lesions in a child. I would think like medullo, but this doesn't look like it's medullo. It looks like a little bit more cystic. I would think even like maybe like a hemangioma, but typically don't see those as commonly in the posterior fossa in children, but also things like pilocytic astrocytomas, maybe infectious causes as well. Um, yeah.
You pretty much got all of them there. And going back to my new favorite mnemonic, MAGE, medullopilocytic brainstem glioma, posterior fossa ependymoma. So again, similar, you nailed all of them, but this wouldn't be neuropathic if it was the same diagnosis as last time. So I can tell you it's going to be different. In terms of treatment, obviously we need diagnosis, we need to treat. What do you think of the ventricles here?
Yeah, I mean, it looks like she has like some, element of obstructive hydrocephalus. And so I forget the exam, but was she kind of like awake, arousable, or was she kind of a little bit more somnolent, appearing? Um,
Yeah, I mean, she's interactive, but obviously, she has these symptoms.
yeah. So I think if she's awake, interactive, I think this is probably, this has probably been going on for some time, and that's why she's not obtunded. It's not like an acute hydro. Nonetheless, I think for diagnosis and treatment, we'd have to do surgery to kind of resect the lesion, but then we'd also have to treat the hydro. So um, I would think either preoperative EVD to kind of help the ventricles come down a little bit and take off some of the mass effect, and then and then go for the lesion, or yeah, I think that's what I would recommend.
Yep. Okay, so again, you're treating both the hydrocephalus that's there. You have that in mind, and you're also treating the tumor, which is there as well, for both diagnosis and mass effect relief. So that's what happened. Surgical resection with an EVD in place. And why don't we go to the pathology slides now? Dr. Gultika, these are the slides.
Can you hear me now?
Yep, and less echo.
Okay. No echo, right? All right. So this, I must say that compared to the previous case, the MRI is really, really much more typical for a pilocytic astrocytoma with the cystic component, no edema, well circumscribed, sort of lateralized in the cerebellum, etc. So anyhow, I just wanted to show you a touch prep or a smear prep intraoperatively that shows these low-grade looking nuclei with some bipolar processes, which is really typical of a pilocytic astrocytoma. You can see several examples. Why do I emphasize bipolar? Because typically bipolar astrocytes don't really exist too commonly in the nervous system. Most astrocytes have stellate multiple processes. So this is a unique situation where you can see two processes in an astrocytic cell, which happens to be a tumor cell here. So it's very typical. Next, please. So here you see one of the characteristics of actually pilocytic astrocytoma. On the right side of the picture, there's a dense woven background, and on the left side there's a looser area, just like a schwannoma. You do see this in pilocytic astrocytomas, looser background versus denser background, and a moderately cellular tumor tissue. Next. On high power on chemotoxin and eosin, you still start appreciating the bipolar cells, astrocytic cells, bipolar processes, low-grade nuclei, round to oval, no appreciable mitotic figures, or significant atypia. Next. This is the other area, the denser area with tightly woven fibrillary background, but the cells are similar. Next. Here you see the telltale Rosenthal fibers, which are alpha B crystalline deposits, these elongated, almost carrot-shaped, of course, depends on the plane of cut, right? You can see them as round figures or elongated figures of reflective, bright red structures. There's plenty of them in this particular field, Rosenthal fibers. Next. When the tumor goes to the subarachnoid space, then it starts to form these weird morphological patterns. In this case, you can see these lobulations of tumor tissue surrounded by septations of fibrous tissue. This happens again when the tumor spreads into the subarachnoid space, induces, I guess, fibroblast development and desmoplasia. Next. This is glial fibrillary acidic protein, GFAP stain, supporting the astrocytic differentiation. Next. Here is neurofilament stain. This actually depicts the brown reaction product, shows you the adjacent cerebellum, which is atrophic, surrounded by tumor tissue, which is blue. So you can see that, number one, the tumor tissue is not staining with neural markers. Number two, you can beautifully identify the, again, compressed atrophic cerebellum. Next. Ki-67 index is really, really low, around 1% perhaps. And I didn't show you these, but the tumor was negative with the typical adult astrocytoma markers such as IDH1 mutation, ATRX loss, P53, all of that were negative. And this case, I believe, is BRAF fusion positive by molecular means. So everything fits: morphology, radiology, age group, molecular diagnosis, pilocytic astrocytoma.
All right, excellent. Thank you, Dr. Gultekin. So going back to our PowerPoint, here we go. Here are just some images of the procedure, similar to above, similar approach to the posterior fossa suboccipital with C1 lami, and you can see the good resection was achieved. And here's some intraoperative images of the tumor coming to the surface, and also during the resection there as well. So pilocytic astrocytoma was the diagnosis. It is a low-grade glioma, most common in children, but you do see it in adults, in young adults, and in both the brain and the spine. Radiologically can appear with a cyst, and we always remember that enhancing nodule component. Rosenthal fibers is the buzzword, as Dr. Gultekin explained in the images. And as more and more genetic data comes out, the involvement of the MAP kinase pathway, most frequently that BRAF mutation that was mentioned, is becoming more apparent. So much so in the latest WHO classifications, it is becoming a big component. Equal occurrence in men and women, boys and girls, and it's the most common glioma in children and the most common glioma during the first 2 decades of life. As previously mentioned, it is found throughout the brain and the spine, but most commonly and prototypically on boards, it's in the cerebellum, but nonetheless, it can present in all these other locations as well. Clinically, it's really a tumor dependent, location dependent presentations. And in the setting of optic pathway tumors, you must consider NF1 as a diagnosis. They typically are well demarcated, enhancing solid lesions with a cystic mass, enhancing neural nodule, but not always. That's, I think, important to remember. Not always does it need to have an enhancing neural nodule. It predominantly is a solid, circumscribed on histology with a biphasic appearance, as previously mentioned. Treatment is a primary gross total resection. Adjuvant therapies are considerable, and today there are variable success reports for progression control using MAP kinase pathway targeted therapies. Prognosis is very good. It's very favorable in all settings. And one of the more bigger predictive factors of poor outcomes include their location, how deep it is. Supratentorial have been shown to be have a worse outcome than infratentorial partial resection and younger age. In adults, consider anaplastic features as well that have been reported with no definitive WHO grade 1 there, and there is a variant in the current classification with an unclear prognosis as well. Just quickly to go over what we love, the MAP kinase pathway. More data is showing that, alterations in this pathway both are involved in these tumors, but also can be targeted in these tumors. And there is a set of inhibitors targeting BRAF as well as MEK1/2 that are coming out, being targeted for both these pilocytics refractory to treatment, recurrent, as well as other low-grade gliomas. And you can see they're all in various combinations of clinical trials right now. The MEK inhibitors a little more ahead of the BRAF inhibitors. So let's keep moving with this. We'll go to someone a little older now, a 64-year-old female. Let me see who is on. Yeah. Tyler, are you there?
Yeah, I'm here.
Okay, awesome. Let's go with a 64-year-old female. She had a left eye tumor in an outside hospital removed, and she was told in 96 that she was a small residual, but it was benign. She can't remember what it was. And then almost 20 years later, had left proptosis, and I was treated at another outside hospital with enucleation, no radiation history, doesn't recall any chemotherapy either. Now it continues with left. Sorry, that should be proptosis, not protosis. She had a previous aneurysm embolization, but otherwise an unremarkable medical history. Outside the proptosis, her and lack of left vision in the left eye, as you can imagine, she's otherwise intact. So she would proceed to go get a CT scan, and this is what she presents to you with. Why don't you go ahead and just explain, or just tell us what you can see here in the CT scan.
Sure. So there's a left, the one from left to right. It's a axial CT bone window, then like a parenchymal window, and then coronal on the far right. You can see that in the left forward well, so there's evidence of a prior craniotomy, kind of like a sphenoorbital, or like a orbitozygomatic potentially craniotomy. But anyway, looks likely there's some sort of material that's like isointense to, I guess it's fat packing in a prior resection potentially versus maybe tumor growth within the left orbit.
Okay, so something that doesn't look great.
Yeah, not there normally. Yeah.
In the absence of any other imaging, and this growing concern and symptom, what do you think could be a management course for this, and then go to a differential after?
Yeah, so I would guess, given her history, it sounds like she may have had like a sphenoorbital, like meningioma potentially, or some sort of other pathology. Obviously, if there was any residual left from the first resection, there's risk of recurrence. So may have been slowly growing all these years.
Yep. Okay, great. And then so differentials, as you just mentioned, meningioma, being benign, being told it was benign, and then the ability to recur. Within these orbital tumors, obviously they're not always the most common thing we see, and so solitary fibrous tumors are a consideration. Lymphoma, metastasis, even though she denied any history of cancer otherwise, and sinonasal tumors could be also at the bottom of the list with extension into the orbit. So for treatment, if you wanted to go for both diagnosis and a treatment, what would you consider for her as she
Sure.
sits?
Yeah, at this point, I mean, given that she's blind in her left eye, I mean, I think you could probably do a more radical resection. Just obviously, like the reconstruction might be the more complicated part of that procedure. But you could probably use the craniotomy that was already there and at least significantly debulk. You could also consider, I suppose, if not surgery or with surgery, either radiation alone, or probably more likely like resection and then radiation to like anything residual.
Yeah, yep. And so, but nonetheless, you would most likely need tissue for diagnosis.
Oh, true, right, yeah.
So you could help guide anything if you weren't able to keep going, and so yes, you would probably proceed to the OR for maximal safe total resection. That is what was done. Dr. Gultekin, I have the pathology slides here. If you wanted to.
Yes, so variably cellular tumor. In the upper center, you can see these broad, elongated collagen bands. On the right top, you see a more cellular area of the tumor, which has a kind of a haphazard, disorganized pattern, does not have the usual attributes of meningioma, which has more like lobular growth, whorls, some warm bodies, etc. You don't see those. You again see these pink, big chunks of fibrous material. So these things remind us the solitary fibrous tumor, previously variably called solitary fibrous tumor or hemangiopericytoma with certain morphologies. Nowadays, we put them all together. Solitary fibrous tumor hemangiopericytoma is now a spectrum called SFT, and the immunohistochemical characteristics are seen below. CD34 positivity of tumor cells, which is a cytoplasmic and membrane marker. But the defining change or alteration is the STAT6 alteration, which you can detect by immunohistochemistry. It's a defining marker for solitary fibrous tumor. Anything that is STAT6 positive is going to be a solitary fibrous tumor. You cannot have a meningioma with a STAT6 positivity. So that's our diagnosis.
Thank you, Dr. Gultekin. Solitary fibrous tumor is what we have here. This patient, it's fibroblastic tumor. And the buzzwords here are the staghorn vasculature and STAT6 gene rearrangement. And as Dr. Gultekin mentioned, previously known as hemangiopericytoma as well. In terms of its occurrence, equal in men and women, and more typically occurs in adults, which was where this patient fit in age-wise. Symptoms are dependent on the anatomical site and location, but it is worth noting that these tumors typically present as slow-growing, painless masses, which goes in line with the patient's presentation, taking many years for recurrence. On imaging, which we had CT, isodense to the muscle with heterogeneous contrast enhancement that wasn't available. The case actually proceeded without MRI. There was obvious lesion that needed treatment. But if you were to take it to MRI, typically you see T2 hypo to hyper variable intensity signals. So treatment, surgical resection remains the gold standard with long-term surveillance, given how likely these are to occur later. Radiation therapy may improve, but it's not gold standard, and there was no evidence that I could find saying that chemotherapy was a necessary adjuvant treatment. Again, just going over the thing is a staghorn. Again, is the buzzword for these types of tumors. STAT6 staghorn vasculature here. As Dr. Dr. Gultekin had mentioned, highly sensitive and specific marker is this STAT6 nuclear marker, which can also be complemented by the CD34 and the gene fusion. Prognosis is good with about 1/3 at most with recurrence rates and a disease-specific survival at 10 years of over 70%, for which this patient fell into. Excellent. So let's go to the last case of the day. We've done all the PGY2s. Oh, Vaja. Are you there?
Yeah, I'm here.
Okay, excellent. Let's bring this home. This here is a 51-year-old male. And by the time the patient presented, already had a nephrectomy for renal cell carcinoma, and presents with 6 months low back pain and some paresthesias in the lower extremities, and came to Jackson from an outside hospital. Apart from what's listed above, no significant past medical history. And so on exam, neuro exam, patient is full strength and does have reduced sensation distally in both legs, and has increased reflexes in the patella on both sides. No bowel bladder issues. So what are you thinking, and what type of imaging would you get?
Yeah, I mean, it's possible he has, some kind of.
No. We have lost oh, there he is. Vej, are you there? I think I see you, but I don't hear you. I'm sure you were saying that you think there could be a lesion involving the spine.
Hey, can you hear me?
Yeah, go ahead.
Sorry, I think I lost connection for a sec. Yeah, this guy sounds, it looks like he's myelopathic. He's having reduced sensation and he's hyperreflexic. I think he needs an MRI and a CT as well of the L spine.
Okay, excellent. That's a good place to start.
Or
We
T spine.
actually they actually proceeded with a MRI of the T and L spine, keeping in mind that these patients in the thoracic spine can also present symptomatically. And so, for the sake of time, why don't you go ahead and just tell us what you can see here on the MRI?
Yeah, sure. I mean, it looks like, especially on the leftmost image, he's got an enhancing lesion with the T spine. Based on the axial, it looks like it's both intradural and intramedullary as well. You can see it displacing the healthy cord to the right.
Okay. So why don't we let's go through the sequences that are here, left, middle,
Sure.
and right.
Yeah, on the left you have a T1 MRI with contrast. In the middle you have just a regular T2 sagittal, and then it looks like you've got the axial T2 as well.
Okay, excellent. And let's go over how you described it: intradural, intramedullary, or extramedullary.
Oh, I think it's actually extramedullary.
Okay. And what makes you say that? Anything?
There's like a clear demarcation where the lesion's displacing the cord. It's not like coming from within.
Within, yeah, that's a good way of looking at it. Excellent. And so let's go. So you mentioned intradural, extramedullary. So what's going through your mind in terms of differentials in that
Yeah, I
sense?
mean, classic differential for these intradural extramedullary lesions are going to be like a neurofibroma, a schwannoma, rare instances, dural-based Mets, and meningiomas.
Excellent. So, as we said, Mets, schwannoma, neurofibroma, meningioma. And given the patient's history of a previous cancer, any other type of imaging you would want?
Yeah, I mean, he definitely warrants a CT chest, abdomen, pelvis.
Mhm. Exactly. Oh, there we go. And so there was a negative for any concern of recurrent of disease. So let's go ahead and talk about the optimal treatment for both diagnosis and treatment. Now the patient is symptomatic. So, well, what are you thinking?
Yeah, I mean, he's symptomatic. He's clearly myelopathic on exam. The cord's being actively displaced, so he needs to be decompressed for sure. He needs a laminectomy at that level. And then he also warrants, resection or at the very least biopsy of the lesion as well.
No, that's great, great. So we've already gone through that, and here is just some examples of the case. A gross total resection was achieved. Here's the image on ultrasound and on the tau. Dr. Gultekin.
Yeah. Yes, so we have a schwannoma here, and the characteristics, as you can see in the gross sections, cut surfaces, there's a cystic appearance here, cystic degeneration in the top picture, variable cellularity, darker areas represent Antony A, lighter areas represent Antony B, which is better seen on the picture on the right side, where that vacuolated area is Antony B. The right side of that picture is Antony A with more denser background. And the cells, if you look at the picture at the left bottom, they are spindle cells, they are low grade, and you see a Verrocchi body forming with the palisading of the nuclei on both sides of this nuclear free zone in the stark middle of the picture. So Antony A, Antony B, spindle cells, Verrocchi bodies, cystic changes. It's a schwannoma grade 1.
Thank you, Dr. Gultekin. So schwannoma. And so what's interesting in these cases is naturally you could think that this patient may have had a MET given his previous history, but it has been reported in previous cases, what we're describing here, that this is almost a separate tumor to the previous primary tumor, but again, not very common. So to go over some of the basics of schwannoma, these are nerve sheath benign tumors as for grade 1. And you can see multiple of these in the setting of syndromes such as NF2 and schwannomatosis. And there is a great prognosis after gross total resection with very rare malignant transformation rates. Going back to the buzzwords, Dr. Gultekin has already mentioned all of them. Antony A, the Verrocchi bodies, Antony B, with the compact areas being Antony A, and then the loose areas being Antony B. The majority of these are solitary and sporadic, and the peak incidence really is in adult stages, with spinal schwannomas just occurring a little bit older than vestibular schwannomas. These tumors present obviously respective to the location of occurrence, in this case with sensory changes in our patient. They are well circumscribed, and as Vedra had correctly pointed out, they displace adjacent structures. And you could see those MRI characteristics on the examples we showed. And just going back, always trying to remember what these Antony A and Antony B bodies are. Antony A are the compact areas, Antony B are the loose lipid-laden areas, and the Verrocchi bodies are these palisading areas. Again, all key buzzwords for schwannoma. Prognosis, as we mentioned, was really good after gross total, with regrowth possible if there's incomplete resection. Otherwise, transformation is exceptionally rare and can be associated with irradiation and the particular subtype. And so that's the end of Neuropath. I finished a couple minutes early, and I'll pass it on to the next speaker.
Well, good morning. Slight change of pace. I'm going to do a little historical overview of the tradition of transatlantic training in neurosurgery. And in part, it's modeled on this concept of the Wanderjahr or Wanderjahren in German. It's derived from the custom of apprentice journeymen who would visit different workshops after their initial training, and is applied to neurosurgery as really a very interesting article here in World Neurosurgery 2020. The goals were first to acquire new techniques and place their existing approaches and knowledge in perspective. And second, to develop a surgical and personal maturation by observing coping in different environments, societies, and medical systems. And three, to establish a network, including friends and colleagues that you come in contact with. So how did this transatlantic exchange begin? Well, for a long time, of course, it was not an exchange, but a one-way street in which Americans went to Europe, mainly to Great Britain, and in particular to Scotland. And here's an example of one of the earliest physicians in the colonies, and that was John Redmond. He was born in Philadelphia, as you can see, in 1722, and died after the United States was created in 1775. And like most individuals providing care in the colonies, he was really initially a pharmacist or apothecary. And it's kind of interesting because now, more than 300 years later, we've returned to that same kind of model. If you remember, perhaps if you weren't in the hospital, but out in the community, you would go to where? Your pharmacist to get those shots. And pharmacists are enlarging their domain in a sense of providing patient care, returning to what was existing in the American colonies. So after training and moderately successful career as a pharmacist, he wanted to really become a physician. He went off to Bermuda. Bermuda was under British rule, and then to Edinburgh, Paris. Finally, in Leiden, he obtained his medical doctorate, returned to England and spent time in Guy's Hospital, and then returned to Philadelphia, one of the few truly physician-trained individuals in the colonies at that time. Next was that I picked out John Morgan, who was born in Philadelphia in 1735. And he graduated from the recently founded University of Pennsylvania, founded by Benjamin Franklin. And like others, you'll see he apprenticed with Redmond while at Penn, but really as when Redmond was an apothecary. Then, not as a physician, he joined the army from 1757 to 1760 as a lieutenant in the French and Indian Wars. And, this is a historical event that perhaps many of us don't remember. Well, I was not alive at that point, to put rumors to rest. But look at this map. You can see that Pennsylvania, for example, the western edge of the state hadn't been outlined. And this war went on for from 1754 to 1763, was really quite violent. It was the British and the colonists against the French, and both sides had Indian colleagues who on both sides was quite a vicious hand-to-hand combat with many massacres occurring. So he finishes in the army, and then he goes off to Edinburgh, obtains his MD, and then he does his quote tour, end quote, of Europe. He goes to France, Italy. He's made a honorary member of the Royal College of Surgeons in Paris, as well as the Royal Colleges in England and Scotland in medicine. He returns to Philadelphia and then founds the first U.S. medical school, that's the University of Pennsylvania, in 1765. And then in part because of the relationships, if I go back, you can see down at the bottom, I don't know what, there we go, that George Washington ran a campaign in the French and Indian War, and through his association with Washington, he became the Director General of Medical Care. Now, interestingly, a colleague of his, William Shippen, who was here, he and Morgan had a rather difficult relationship. They ended up suing each other. Shippen brought action through the then Continental Congress to have Morgan removed as the medical director for the Army, and this continued on and went in some ways in much more official manner reflects the future rivalry that we saw between Cushing and Dandy in the 20th century. Here's another more well-known physician who also went to Edinburgh. That's Benjamin Rush. Rush, born in 1746, he graduated from Princeton at age 14. And again, he apprenticed to Redmond. He went off to Edinburgh and obtained his MD. And then again, following in the footsteps of some of the other individuals, Morgan and Shippen, went off for a tour through France, Italy, and Spain, visiting hospitals. And he returned to America and became the father of American psychiatry. He developed a straitjacket that was thought to be more humane. When you look at it, you would wonder how that could possibly be designated as such. But he was then he was well known for his advocacy for therapeutic bleeding. And he was one of, quote, 4 doctors. Turns out that he was the only MD. The other 3 were really had been trained as apothecaries. Here's his signature on the Declaration of Independence, right above Benjamin Franklin's. So now we skip ahead by 100 years or so, and here we encounter this rather stern-looking man who should, I think most of us probably would recognize, maybe not his picture, but this is William Halsted, who developed the surgical residency principles. He was cut from a totally different cloth from what we've seen from the earlier physicians. He came from a wealthy family, went off to Andover Academy or Phillips Academy in Andover, Massachusetts. He was not a great student. He had to study. His average at Yale was not measured by his grades, but by his yards per carry. He became a captain of the football team, big-time baseball player and road crew, but his academic achievements were not outstanding. He wanted to go to medical school and had to wait for a period of time. He finally got admitted to Columbia Physicians and Surgeons, and in his second year, he developed an interest in surgery, in part because he rotated through Bellevue Hospital, misspelled here, and became aware of Lister's technique, which was really aseptic approach to dealing with surgery and the patients in general. But he put his mind to work. He graduated at the top of his class, and then he went off, he stayed in New York where his family was quite prominent, became a house physician at New York Hospital. And then in 1780, 1878 through 1800, he did the quintessential European tour to Germany, Austria, and Switzerland. And at that point, I think the individuals he interacted with indicates the seriousness of his efforts. Here's all the general surgeons, and after all, the surgeons in those days, except for some who specialized in ENT, were general surgeons. And if you look at some of these names, and those of you who had some general surgery training, which was when I was training mandatory to do at least a year in general surgery, you know Bill Roth from Bill Roth 1 and 2, and Chiari and Coker, who was in Switzerland, as you'll see. And then he came back to New York, and he applied the concept of aseptic GI surgery. He performed the first gallbladder extraction, cholecystectomy, and first transfusion. Both of these achievements were performed on his mother, who was in extremis, and he saved her life. And it was during this period that he developed an addiction to cocaine, and then subsequently managed to get off of cocaine by becoming addicted to morphine. And that persisted throughout his life. In 1886, Johns Hopkins was opened, and his friend who he had met in New York, Welsh, who became the dean and head of pathology at Hopkins, recruited him from New York down to Baltimore. And he initiated gradually the education by degree and level of responsibility, i.e. the residency. But the truth is that Osler, a famous physician, really pioneered that effort. Here we see the famous painting of the founders of Hopkins Medical School, painting by John Singer Sargent. Here's Welsh, who I've mentioned, Kelly, the OBGYN, and then William Osler. And interesting, Osler history was written by Harvey Cushing, who won the Pulitzer Prize in 1925 for his biography of Osler. But in the background, and not as brightly shown, is Halsted. And in reality, these three individuals in the front were appointed as full professors. And initially, Halsted was not a full professor. He was just director of surgery. In part, they were concerned about his addiction, which he tried to hide, but nevertheless was obvious to these physicians. But then he gained a faculty appointment and became a full professor. And now we shift over into the neurosurgery realm to look at this transatlantic educational highway. And of course, we start with Harvey Cushing, the first truly dedicated individual in neurosurgery. Cushing was born in Cleveland in 1869. Like Halsted, he obtained his undergraduate education at Yale. He then went off to Harvard Medical School and finished, and then did his internship at Mass General. And he wanted to go into general surgery. I mean, that was really all there was, again, except for perhaps those individuals who focused their efforts in ear, nose, and throat. And he applied to Johns Hopkins for a surgery internship, but Halsted was not enthusiastic about him. And it sounds strange, but if you read Fulton's biography of Cushing, Fulton points out that Cushing at that time was self-assured and appeared very provincial in many ways. But the mafia of support in Boston and in New Haven at Yale petitioned Halsted, and Halsted let him in. But by 3 years later, a very rigorous 24-hour, 7-day-a-week work schedule. He had, in essence, retrospectively, had become, quote, burned out, and he went off to a European tour. And this European tour really set the precedence for subsequent visitors from America to Europe. And who did he see? Well, he started out in London, and he saw Horsley, who was the preeminent, quote, neurosurgeon. Actually, he was a general surgeon of some renown who practiced neurosurgery on the side in London. And Cushing wrote a scathing review of his experience in seeing Horsley operate, which he thought was quite bloody and messy, and certainly not in keeping with the concepts that Cushing would eventually develop. He then went to Liverpool, and here it was really a pure research opportunity to work with Sherrington, who went on to win in 1927 the Nobel Prize for his work in neurophysiology. He went to France in 1901, and he returned to France, as you'll see, subsequently 14 years later when the First World War broke out. He then proceeded to Switzerland and Germany, and in following really in the footsteps of Halsted. In Switzerland, he spent time with Kocher and Kronecker, and I'll come back to his work in ICP and blood pressure, which is known as the Cushing response, but as you'll see, more properly should be known as the Kocher-Cushing, perhaps Kocher Kronecker-Cushing reflex. Then he went on to Germany, and then Italy. He visited Riva Rossi, and it was there that he saw the sphygmomanometer being used, and he brought that back, and that really made general anesthesia more safe, because you could measure the blood pressure, and then it wouldn't be that surgeon would say, okay, let's wake him up, and because a patient routinely would drop their blood pressure and then not wake up. This made anesthesia much more safe. So let's go back to Switzerland and the issue of the Cushing reflex, or the Kocher Cushing reflex. Here's a publication that Cushing, see his name here, published in the last issue of 1901, the Johns Hopkins Hospital Bulletin. And the work that he performed to achieve this and create this article was actually 1 month in Switzerland and 2 or 3 months in Italy. And when you look at this, now let's look at it in a little more detail. You see down the bottom, it says reprinted from the archives of the Italian Bulletin of Biology. So in reality, this certainly suggests that maybe all of this wasn't Cushing's work, even though he's the sole author. And he also then goes on, he says, I'm deeply indebted to Professor Messa de Toro and Kronecker for extending to me the privileges of their laboratory. So the real question is, who really is responsible for this work? And despite that, here are articles in which the Cushing reflex is highlighted, and that's what it's known for, I think, in the United States and even in Great Britain now. And he returned then to France when the World War I broke out. And this is a really interesting insight. It's written by Michael Carey in the Journal of Neurosurgery in 2014, and deals with Cushing's work with the British Expeditionary Force, the BEF, and the American armies in World War I. And as Carey points out, his service began in May of 1917 and abruptly ended in 1919 when the British threw him out of their army. He was cashiered for repetitive censorship violations. And he returned to the American command, but he feared court-martial. The Army file on this matter indicates that the U.S. Army authorities recommend that Cushing be reprimanded and returned to the U.S. for his violation. But that never happened. And there's no evidence to suggest that a court-martial was considered. So it's most likely Cushing's friends, I use the term mafia, came to his defense, and he was protected for his military violations in British forces, and then went on to provide superb service as a physician. And in fact, here's a rather well-known book. It's from the Surgeon's Journal. This is a first edition that was given to me by John Jane when I went off in the Army. And it's really a fascinating and detailed report by Cushing of his experience in the trenches. But again, as Carrie points out, Cushing repeated defying of censorship regulation reveals poor judgment plus an initial inability to be a team player. All you need to do, perhaps the opportunity doesn't exist anymore, is to talk to Cushing trainees to find out what an autocrat he was, and an individual who did not tolerate any variation from his explicitly designed plans. The explanation he offers for his censorship violation showed an ability to bend the truth. Cushing's war journal, this one, is unclear as to what transpired between him, the British, and U.S. Army. It also shows no recognition of the help he received from others who were instrumental in preventing his ignominious removal from the service. I mean, it's a different insight into Cushing's personality and approach to organized medicine. Nevertheless, I think Cushing's experience, the tour that he made through the UK, France, Germany, Italy, set a precedent for neurosurgeons in particular as part of their education. And in fact, here's a traveling fellowship sponsored initially by William Van Wagenen, who was one of the first presidents of the Cushing Society, and it supports travel anywhere in the world. I think there are about 40, it's been in place for 45 years. Most of the awardees have gone to Europe, but now and now to Japan. There hasn't been one to China, but the precedent was set by Cushing. Now here's another individual who followed in the footsteps of Cushing in many ways, and that's William H. Sweet. He was born in 1910 in Caryston, Washington. Now here's Caryston, Washington. It was founded in 1905, and by 1930, it became a ghost town. So it's a small logging town in the forests of the state of Washington. And you can see Rattlesnake Mountains close by. I visited this when we lived in Caryston, when we lived in Seattle. And it's a tiny little spot on the road now. At age 14, he finished high school, and he thought about having a career as a piano player, classical piano player. And so he took off a year, and during that same year, he worked in a lumber mill in his hometown, decided to give it up. His father was a physician. His mother was a university-trained school teacher. He goes off to the University of Washington in 1930, and he graduates in 1930, summa cum laude, #1 in his class of 1,000 students. And if you want to get a sense of what America, and in particular the Pacific Northwest, was like in that era, you should really read this book, The Boys in the Boat. It's about the University of Washington crew who went on to win the Olympics in Germany in the 30s, 1936 Berlin Olympics. And that's the environment in the early part of the book, the description of the 8 lads who rowed this show. And it's really a picture into how Bill Sweet was raised. So after graduating #1 in his class at the University of Washington, he goes off to Harvard Medical School, where he wins a Rhodes Scholarship, and he goes over to Oxford, studies with Sherrington, similar to what Cushing did, and focuses on neurophysiology. But on his vacations, Cushing went to France and painted and watercolors. Sweet goes off to Würzburg for 2 months and learns German, or perfects his German, and passes the Internal Medicine Board of Germany. He then returns to Harvard, where he finishes in 1936. He wants to go into neurosurgery. He does his internship at Mass General, but after 1 year at Mass General in neurosurgery, he heads off to the University of Chicago to work with the world-renowned Percival Bailey, who was one of Cushing's trainee. And then finishing his residency in Chicago, he goes back to Mass General, where he meets up with James White. White and Sweet, of course, writing a definitive book on pain. And he stays at Mass General except for one period, which I'm going to talk about. And in 1961 through 1970, he becomes professor and chair of the Department of Neurosurgery. This is the individual that Roberto trained with, and I suspect he having been up close and personal with Bill Sweet, has many insights in regard to Dr. Sweet. But it's really, what about these dots here? Well, he had a long career in training, but let's look at one of the first dots, which is really, truly remarkable. And that is just after he's finished training as a resident and fellow, and perhaps the most important part of an academic neurosurgeon's life, and that is it's the tenuous period of when you're finished your residency, and then you have to establish your roots in clinical work, in research, in teaching, and so forth. It's a very difficult and challenging period in an academic life. What does he do? Well, first of all, the US wasn't at war at the time, but Great Britain was. He voluntarily returns to the UK to work in the Queen Elizabeth Hospital in Birmingham. So where's Birmingham? Here's Birmingham, right in the Midlands. And along with London, Manchester, Birmingham, Plymouth, these cities were massively bombed during the Blitz. And Sweet stayed there from 1941 through 45 and became the chief of neurosurgery. Highly unusual in the UK to have a Yank, an American, become head of service at one of their major hospitals, and a hospital which, along with 3 other centers, was primarily responsible for all head injuries in the UK, in the civilian, and then with the invasion of Europe, the beaches right down here, with all the Allied troops that could be transported, came back to these centers for care. He was appointed the regional consultant in neurosurgery to the British Emergency Medical Services. And at the end of the war, the Brits wanted to give him an honorary degree, which is course, prohibited to a U.S. citizen. So they gave him the Majesty's Medal of Service in the cause of freedom. And I was then in England 25 years later. Wherever I went and I ran into neurosurgeons of a certain age, they instantaneously would ask me if I knew Bill Sweet, and then went into a soliloquy about what he did for the civilian and military, the injuries in the civilian and military during World War II. And if you really want to read a day-to-day review of what on, Floyd Barringer was a Quaker, was a CO, conscientious objector, and he volunteered to go over to Birmingham and join Sweet. He became Sweet's first assistant, and this book details day by day the immense clinical load that they faced really on their own for 4 years. It's a very interesting book. Okay, so at a certain point, the tide reverses, as all tides do. And then the Brits started coming to the United States. Here's another book I recommend, but this is about the Revolutionary War, written by Rick Atkinson, superb writer, wrote a 3-part series on the American Army in Europe and Africa in World War II. This is the first of 3 dealing with the American Revolution. So people, surgeons from all over the world, outlined in this article by Molina in the Journal of Neurosurgery in 2021, came to the United States. And of course, they came and went to Boston to spend time with Cushing. And I'm just going to highlight 3 of them. And all of these 3, as many others, came supported by the Rockefeller Foundation. Now, Cushing had a very special relationship with the Rockefeller Foundation. And, he was in essence the individual who would give the nod to who received these fellowships. And the first one was Norman Dott, a Scotsman. And here's Norman Dott. I actually met Dott after he retired when I was in England. Excuse me. He came to the States in 1923 to 24. He became Britain's first full-time neurosurgeon. And he really had to scrape by because the general surgeons, many of them thought they could do neurosurgery, had a smattering of training, certainly knew how to take care of compound depressed skull fractures and other aspects of neurotrauma. But nevertheless, he went on and developed quite a career and a distinguished career. He developed guidelines for treating subarachnoid hemorrhage. Oops, I can't, what's happened to my arrow? Oh, yeah. Introduced angiography for the diagnosis of subarachnoid hemorrhage. He was first to do direct surgery for a ruptured aneurysm. He didn't clip it. They didn't have clips. Dandy was the first person to clip an aneurysm, but he used a muscle wrapping technique. And he introduced the criteria for carotid ligation for aneurysmal subarachnoid hemorrhage, and came to realize that it was only the proximal aneurysms on the carotid circulation, such as posterior communicators, in which that seemed to be appropriate, but subsequently in a randomized trial, McKissick and others et al. Showed the advantage of carotid ligation over bed rest therapy. Second individual who came to visit Cushing on a Rockefeller Foundation that I want to highlight, Hugh Carnes. He came after Dott, 1926 through 27. He was Australian, born in 1896, died in early death 1952. He won a Rhodes Scholarship and went off to Oxford and never returned to his native land of Australia. In Oxford, he was distinguished athlete and student. Road crew, played rugby, which was, you know, he's Australian. He had to. He qualified in surgery and then, as a general surgeon, developed an interest in neurosurgery while he was in general surgery. And then journeyed to Boston in 26, 27 with Cushing. Here's a picture of Cushing with the omnipresent cigarette in his hand. And they're standing in front of the Newfield Institute. Well, something happened here. Well, in any event, Carnes had this concept of building, in essence, an MNI, a Montreal Neurologic Institute, but and the Rockefeller Foundation, which funded the MNI initially, turned them down, but they assisted and they put him in contact with Newfield, who was at that point equivalent of a billionaire, a car manufacturer, and Newfield agreed to endow a surgical focused, in essence, medical school at Cambridge, and off he went, built this Newfield clinic and surgical effort. And here he is subsequently in the Army. He was interested in a wide spectrum of topics in neurosurgery, but focused on head trauma. And it was interesting, he did many experiments on helmets. And when you read the experiments he did and the write-ups, it's very similar to the types of report that are still ongoing in regard to football injury prevention or head injury prevention in football. He also focused on motorcycle riders who at that point didn't wear helmets, nor do they in several states in this union. He got interested in the motorcyclists because of care he provided to Lawrence of Arabia, shown here on his motorcycle. After his exploits in Arabia in World War I, even though he was made a full colonel, he dropped out of the Army, subsequently re-enlisted and stayed as an enlisted man, and was in a motorcycle accident and died under Carnes' care. And in World War II, again, he continued to advocate for helmets in the Army, which really blossomed in the UK post-World War II. But he created the Mobile Neurosurgery Unit, which the US Army initially was opposed to, but then became widely accepted and utilized. For example, on the invasion beaches, there were 2 neurosurgery mobile units right on the beaches, and one for the Brits. And it had a large impact, which of course was pushed forward in various military encounters that the United States has been since World War II. Now, the third Rockefeller supportee was Wiley McKissick. Now, McKissick was cut from a totally different cloth from the 2 individuals I previously presented. He came from a rather modest background. He attended the City of London School for Boys. He was a poor student in both senses of the word. Financially, he was poor, and he wasn't a great student. And he finally managed to achieve his goal of becoming a physician. After multiple attempts, he got into St. George's Hospital Medical School, London. And he came under the influence of a plastic surgeon, Harold Gillies, who was a remarkable individual in that he applied new principles, in part developed by dentists in France and ENT specialists in France. Gillies applied these principles for facial deformities caused by encounters in World War I. And McKissick was interested in plastic surgery, then neurosurgery, but he couldn't gain access, in part because he was not from the gentry class. So he ended up going into neurosurgery because he rotated through Maida Vale, where was the London more or less center for neurosurgery at the time. The Queen's Hospital prohibited surgeons for holding any appointments at the hospital for neurologic diseases. And he also rotated through the London hospital where Carnes was before he left for Cambridge. And in 1935, he went to Stockholm to visit with Oliva Krona. And it was there that he saw neuroradiology for the first time. And he met Eric Linesholm, who's recognized as the father of neurosurgery. And this insight was, and the future that neuroradiology might play in its contribution to neurosurgery, I think typified McKissick's openness of his mind to new ideas. Even in his 60s and 70s, he was open to new ideas. For example, Hounsfield came to him in the late 60s with this concept of developing a CT scanner. And McKissick said, yes, boom, we'll find the space. And the CT scanner was built in the basement of Atkinson Morley's Hospital. And of course, Hounsfield went on to win the Nobel Prize. But he also then went back to to England, and he recruited a neurologist and a radiologist by the name of James Bull, who became the father of neuroradiology in Great Britain and also had profound influence in the development of neuroradiology in the States. In any event, McKissick wins a Rockefeller Foundation fellowship and comes to the United States. And to a certain extent, I'm sorry to say that Sir Wiley, as he subsequently was known, had a very dim view of Americans in general, and specifically of American neurosurgeons, with some exceptions. He went to the Lay Clinic, where he spent 6 months with Horax, because by then Cushing had been, in essence, relieved of his position at Harvard and now was in semi-retirement at Yale. So he visited with Horax and Poppin, and he maintained verbally and in writing that Poppin was the best technical neurosurgeon in the States. He spent time with Monroe. He visited, sorry, this must have some timer that moves the slides forward. He went to Montreal. By then, the M&I was just getting started. He visited Chicago and Oldfield, and Oldfield is in red because he plays a role in subsequent travels, as you'll see. He has lunch with Cushing in New Haven. And Cushing, of course, had this one little thing he would do. He would serve corn on the cob. He liked to serve it to the Brits, who rarely saw that, just to see if they knew how to eat the corn on the cob. And I think that's in part because he wrote the biography of Osler, as I previously mentioned, that won the Pulitzer. And Osler, when he was applying for the job as professor of medicine at the University of Pennsylvania, three of the trustees took him out to a Philadelphia club, and for dessert they had cherries served to him, and they wanted to see if he knew how to handle the pits. And of course he did it with the palm by putting the pits in a spoon and then putting it on his plate rather than spinning the pits across the room. But that's where I suspect Cushing got the idea of serving corn on the cob to visiting Brits. And in 1941, after the war gets started, he can't get into the military for unknown reasons. But he's offered the position at Atkinson Morley's Hospital, which will loom as an important component of the transatlantic education of neurosurgeons. So Atkinson Morley Hospital, which is known as AMH, opened in 1869, but remained a convalescent hospital until World War II, when under Miss McKissick's leadership, inspirational leadership and insightful leadership, the neurosurgery unit at AMH was established. And then through through McKissick's guidance, he added neurology, psychiatry, and rehab units, and then a neuroradiology unit. Here's the Atkinson Morley Hospital. I suspect not much change from when it was a private mansion of Atkinson Morley. And here it is in 1971, hidden behind this Victorian, rather dreary looking house. It's a larger hospital of about 400 beds. Here's the history written by Terry Gould, an ENT surgeon, and David Utley, who subsequently became the head of AMH neurosurgery. Here's the catchment area. So this was 9 million people that they provided care for. To put it in subarachnoid hemorrhage parlance, they saw between 600 and 900 patients a year, while their catchment area was this big. And the only way they could do that is and McKissick had this idea of testing various therapies in surgery by randomizing them to bed rest or surgery, and a variety of different surgeries. For example, posterior communicators, direct attack versus carotid ligation. He divided the populations of subarachnoid hemorrhages into 5 grades, really in advance of subsequent grading systems, and that way they were able to handle it. So from American perspective, the extraordinary series of clinical studies on surgical treatment of aneurysmal subarachnoid hemorrhage shown here. Here's 3 publications in Lancet. Here, the posterior communicating, well, this is middle cerebral, posterior communicating, anterior communicating. And look here, I mean, each one, several hundred patients randomized in the good grade patients to bed rest or direct surgical therapy or indirect surgery. So, and it was reinforced when the National Institute of Health sponsored a cooperative study of 20 plus centers, one being Atkinson Morley, which contributed over 20% of all these centers to 20% of the patient. And as a result, visits to AMH by American neurosurgeons, neurologists, radiologists, epidemiologists resulted, but these were transient visits, relatively brief, until 1961-62, when this individual, John Jane, who, as you know, became the future editor of Journal of Neurosurgery and transformed that journal into 4 journals, he went over to Atkinson Morley for a year. What about John Jane? Well, he was born in Chicago, 1931. He was University of Chicago undergraduate, medical school, started out in a PhD. He did go up to Canada to the Royal Vic for an internship and came back and started his neurosurgery residency at the University of Chicago. Here's a more accurate picture of what John looked like when he graduated from, I think, college. The residency then was under the direction of Joseph Evans and Sean Mullen. Sean Mullen was an Irishman, very delightful, entertaining guy, amazingly imaginative individual who developed a whole series of new approaches to aneurysms, pituitaries, tumors, trauma, and so forth. Joe Evans was the chair, focused on surgery, and he was really a man of limited words. But it turned out, surprisingly, so was John. John was a man of, or I should say, a young man of limited words, but they were dictated words. And by 3/4 of the way through his residency, he had 250 undictated charts. And Joseph Evans finally spoke and he says, "You're fired." So John had to find a new position and was unable to. So he goes off to the M&I and he focuses really on neuropath, neuropsychology, neuroradiology, but not neurosurgery. So he was unable to secure a return into neurosurgery during those years. And I mean, the reason, here's a change in the picture. This is because perhaps natural maturation, his hair changes, his look changes, but perhaps some of it is related to this black cloud that was hanging over his head, and which he, readily admits was a adolescent-like behavior by not taking care of the dictations. So he decides, okay, I can't get into position in neurosurgery in the States. I'm going to try to find a place in England. And off he goes to Atkinson Morley and spends a year with Mr. McKissick, or Sir Wiley, as he's subsequently known, and his colleague Alan Richardson, who takes over AMH when McKissick retires. And here's what John achieved in the year he was there. Series of publications, and I just want to point out he's the first author here with McKissick. It was unheard of that McKissick would not be the first author. I think it indicates the admiration and appreciation that Sir Wiley had for John. Here's publications with Alan Richardson. Here's Alan. So John finishes up that year, still can't find a position in neurosurgery. So he decides to go back to the University of Chicago and Duke to finish off his PhD in experimental neuropsychology with Irving Diamond. But he's still trying to get back into neurosurgery, but this cloud's here. Then he hears of a job in Chicago, his hometown, at the Illinois Neuropsychiatric Institute, and that's with Olberg, who McKissick visited in 1938 on his Rockefeller Fellowship. So John contacts McKissick via Alan Richardson. McKissick contacts Olberg, and poof, the black cloud is dissipated. And here's a picture of John right here, Olberg. This is Dave Yashon, and he's back in neurosurgery, which I think suggests that F. Scott Fitzgerald's quote that there are no second acts in American lives, end quote, is not totally correct. So following his chief residency at the Illinois Neuropsychiatric Institute, he joins the faculty at Case Western Reserve, advances from assistant to associate professor, and then at the tender age, I think of about 38, he becomes the professor and chair of the Department of Neurosurgery at UVA. And one of his goals is that the residency will have a 12-month rotation to Freedom Fields Neurosurgery Unit in Plymouth, England. This comes about because at the M&I, he met a neurosurgeon in training, Henry Gossman, who opens up the unit at Freedom Fields. Now, where's Plymouth? May not be well recognized, but to many Americans, it's way down here in the so-called West Country, with Cornwall and Devon. And that neurosurgery center had a catchment population of about 1.2 million. It opened in the late 60s, early 70s. And I was training in general surgery. John convinced me that would have been a mistake, and that my neurosurgery was the way to go. And so I followed John down to Charlottesville, and he sent me off as a second resident to Freedom Fields in Plymouth at the Plymouth General Hospital. Here's Freedom Fields Hospital, small little hospital, but behind it is Plymouth General Hospital, where the neurosurgery unit was established. And in 1970, it consisted of the following consultants: 2 neurosurgeons, 1 neurologist, 1 neuroradiologist, and 1 neuroanesthesiologist. And the house staff consisted of a, quote, senior registrar, that was the UVA resident, for neurosurgery and neurology. And then 2 or 3 house officers who were either medical or surgical interns with 0 interest in neurosurgery. They were just putting in time to get credit for some type of surgical rotation. They were, without a doubt, very knowledgeable about the right pubs to go to, and were a lot of fun. They were a good crew, but they really had not much of an interest in neurosurgery. We had 38 to 42 adult beds with a quasi 4 beds that could be converted to an ICU, which would be visited by an anesthesiologist once a day. And then there was a peds ward. And contrast this to today, it's part of a university medical school, the Peninsula Medical School, which is part of the University of Plymouth. It's a 1,000-bed hospital. There's a department of neurosurgery with 8 neurosurgeons and a residency of 8 years, because the training of neurosurgeons in Great Britain about 20 years ago started to change dramatically. It wasn't a single person going around from one program to the other, but became organized by the Royal College. And so they have residency, and I visited it recently. It's an incredibly well-equipped hospital. Most Americans probably know Plymouth because of Plymouth Rock, shown here. Here they left from Plymouth. These are the steps, the Plymouth steps. Plymouth itself is 250 population, extensively bombed in World War II and rebuilt. Some highlights: Hodgkins and Huxley described the ionic basis of nerve conduction at the world-famous Institute of Marine Biology, one of the first institutes dedicated for the study of marine biology. But it's got some other very important civic institutes. In the Barbican, which is the old part of town, it's the site of the Plymouth Gin Distillery, founded in 1431. Here it is. And here's one of its products, a real buy, Plymouth Gin, for $119 for this special bottle of gin. Quite attractive city. I went off there, spent a year there. John called it a paid year's vacation. I'm not sure how he got this idea that we were frivolously jaunting around the UK and Europe. Thought it was a vicious rumor. And but nevertheless, we did do that. Here we're at Land's End, which was 4,277 miles from the UK. And for 20 years, residents from UVA rotated through Plymouth. Subsequently, they rotate through a hospital in Auckland and New Zealand. And many of these folks in the first 20 years went on to either run a department of neurosurgery or be program directors. and have endeavored to send their residents abroad. While I was there, John said to me, go see AER at AMH. I wasn't sure what kind of code that was, but AER stands for Alan Richardson. And of course, AMH was Atkinson Morley's Hospital. So I went up to Atkinson Morley's Hospital and had a highly productive decade and a half interaction with Alan and his colleagues at AMH. We produced a series of papers because there was this reservoir of thousands of patients that had been randomized to bed rest therapy. So I had the opportunity to define the long-term follow-up. And here are these papers, what I had previously shown in grand rounds here. And so we had conferences back and forth. Here's in fact a breakout session on one of those conferences. And in 1982, 83, I was offered an opportunity to head up the department at the University of Washington in Seattle. And I was thinking about that, but I was also thinking of AMH, shown here starkly, better in a, looking nicer in a watercolor. And I decided if I went out to Seattle, I would create the same opportunities that John had in his early life and that the residents of UVA had. And I wanted to do the same thing if I went out to the University of Washington. And it was really with Alan's help, who really fought the National Health, NHS's bureaucracy and allowed this to happen, whilst I had to fight my own battles with my future colleagues and on the faculty who were not impressed with the idea of sending the residents away for a year. But nevertheless, we were successful. And for the next decade, here's the list of people who, residents who went off to Atkinson Morley's Hospital, eventually to a year staggered so that there weren't residents at the same level at the same time there. And every one of these residents, man and woman alike, thought it was one of the best years of their lives. Here's Matt Howard, who's, you may know, is chair of University of Washington, University of Iowa, Department of Neurosurgery. He said, quote, "The year was a special part of my residency, the cultural and surgical experience, an incredible once in a lifetime opportunity. I wouldn't trade it for anything." Here's Mike Haglund, who was distinguished Duke Professor of Neurosurgery, Program Director, Vice Chair of Education, said amazing and life-changing, great experience. This was the same comments that I received from the residents at UVA who rotated through Plymouth, as well as the 20-year experience from all the residents who rotated from the University of Washington to Atkinson Morley's in Wimbledon. I neglected to mention Atkinson Morley's was a hardship tour to be sent to Wimbledon next within a tube stop of London. And here are the most recent Gavin Britz and Jury Grant, both of whom now rotate residents through Atkinson Morley. And I would be remiss in not acknowledging the help that I had from Alan Richardson. I've already stated that, but David Utley, who wrote this book. Here are the Utleys visiting Seattle. I made a point of having many of the folks at AMH and neurosurgery appointed to the visiting faculty at UVA and Seattle. And these individuals in particular, Alan Richardson, David Utley, and this last individual shown here, punting in Cambridge, one of our residents who had been a SEAL in the Navy, Tom Manning. But this individual, of course, is Henry Marsh, now a famous author. So in retrospect, the concept of the Wander year, the goals being to acquire new techniques and place existing approaches of knowledge and perspective, I think was achieved for residents' surgical and personal maturation by observing and coping with a different environment, society, and medical system. I know for a fact that these individuals came back from this year significantly enhanced in multiple dimensions, not just their surgical knowledge and judgment, but also their personal maturation. And they established, as evidenced by John Jane's experience and many others I could attest to, networks and that involve friendship and colleagues. And I'll close with a few other somewhat humorous remarks. It was clearly a year's paid vacation. Here's Paul Elliott visiting the pyramids. Dave Newell, cultural events in Soho with Mark Mayberg. Here is Matt being sartorial instruction and dress for success. Here's someone who actually is dressed for success, Aaron Filler, who went on to do research for an additional year with a 4.7 Tesla at St. George's, where he developed diffusion tensor imaging and MR neurography, and his work resulted in income to the UW and our department and St. George's. And here's a article in the New York Times about his work way back in 1993 when he was still a resident. So with that, I'll stop and thank you for your attention.